Good evening, good morning, and good afternoon from whichever place of the globe you have logged in. I am Dr. Vishwanath Satyanarayanan. I'm a senior medical oncologist at Apollo Hospitals in Bangalore, in India, and I'm going to be the host for tonight. And we welcome you all to this ASCO endorsed CPOM Foundation webinar once again. And a very interesting topic tonight. It's on molecular understanding and treatment landscape of gliomas. And it is the last of the ASCO endorsed webinar series for this year. But I'm sure we're going to come back next year again for this webinar series. So here are sponsors, NATCO, Alchem, Dr. Reddy Labs, and OncoMinds, who have been very generous with their educational grants. A few ground rules before we start. Please ensure that a good internet connectivity is there for a seamless experience. And all the attendees will be on mute only mode and mute and listen only mode. And attendees can ask questions by typing in the Q&A section. And this session is being recorded. A few words about our foundation. It is mainly started by the medical oncologists, myself, Dr. Vishwanath S., Dr. Santosh Kumar Devdas, who is a professor at MS Ramaya Hospitals in Bangalore, Dr. Poonam Maurya, she's the other trustee. She's again a medical oncologist at Apollo Hospitals in Bangalore. Dr. Chandrakant MV, another medical oncologist with Narayana, Kolkata, and Dr. Rachin Shetty, who is a senior medical oncologist at AJ Shetty Hospitals in Mangalore, India. And this is the agenda for tonight. So we have the first talk by Dr. Matthias Holdhoff, and that's on molecular classification of gliomas and management of low-grade gliomas. And this will be followed by management of high-grade gliomas in the first-line setting by Professor Dr. Rakesh Jalali. And subsequently, we have Dr. Manmeet Ahluwalia, who will be giving a talk on relapsed glioblastomas. And then we have two interesting case presentations by our very enthusiastic fellows, Dr. Trisha Shetty and Dr. Varsha Bhandarkar. And then we'll have a summary by and concluding remarks by Dr. Rachin Shetty. So I would have request Dr. Santosh Kumar Devdas to do the honors of introducing our first speaker for tonight, Dr. Matthias Holdhoff. Over to you, Dr. Santosh.
Thank you, Dr. Vishwanath. Today I have the pleasure of inviting and introducing Dr. Holdhoff. He is a co-director at Brain Cancer Disease Group, Sydney Kimmel Comprehensive Cancer Center. He's an associate professor of oncology, neurology, and neurological surgery at Johns Hopkins University School of Medicine. He's a renowned expert in primary brain cancers and central nervous system lymphomas. He has completed his medical training in Berlin and advanced training at Johns Hopkins, including research at the Ludwig Center for Cancer Genetics and Therapeutics. He is a clinical investigator with a focus on novel trials and biomarker studies in malignant gliomas and CNS lymphomas. He is widely recognized for his contributions through numerous awards, clinical trial leadership, and has published research in esteemed journals. He is a passionate mentor, educator, and he co-directs Johns Hopkins NIH Neuro-Oncology Fellowship Program. Over to you, Dr. Matthias Holdhoff.
So Dr.
Thank you
Holdhoff
very much.
Is a talk on molecular classification of gliomas and management of low-grade gliomas. Over to you, sir.
Thank you very much. So I need to share my slides. 1 second. So, well, good morning and good evening, depending what you choose or where you are. First of all, thank you, Dr. Santosh, for this very kind introduction. It's my honor to talk about one of my favorite topics, which is the molecular classification of gliomas and the management of low-grade gliomas. I have a couple of disclosures. And I'm going to start with an overview of the and sort of introduction of the 2021 WHO classification of gliomas. I will talk about IDH mutant gliomas, lower grade gliomas, and the evolving role of IDH inhibitors in neuro-oncology. So infiltrating gliomas are really the bread and butter in our neuro-oncology practice. So this topic is close to to our heart. And the majority of our cancers in clinic that we see are glioblastomas, but we also see other types of astrocytomas, oligodendrogliomas, sometimes lymphomas. I think the new classification is best reflected in its complexity by this figure that I plagiarized from, with permission, from Craig Babrinski, who was a neuropathologist at Northwestern. You can see that the WHO classification, first of all, there were numerous different versions over the past years, but that the sheer volume of knowledge and understanding of these tumors has improved. So this is a little bit intimidating when you order this book and it's about 2 pounds. So how do we understand the most important take-home points from the new classification? So I'm starting with an outdated view of how we used to understand gliomas. We thought about, immunohistochemistry, about histopathology. Initially, oligodendrogliomas versus astrocytomas. There used to be a category of so-called oligoastrocytomas, really phenotypically described. And the pathology reports used to be very short. Sometimes it would just say astrocytoma grade 2 or glioblastoma, and that was it. So things have changed a lot. We now know that oligodendrogliomas are defined by presence of the co-deletion of 1p19q, and they also need to have an IDH mutation. We still use grading, and we draw this arbitrary line between low grade and high grade. It's not that straightforward anymore, but that's how we used to understand these cases. We also, these diagnoses, we also learned that there are more genetic events that happen when these tumors transition to a higher grade. So what do these tumors look like under the microscope? You can see on the left side an oligodendroglioma, really well-organized, kind of peaceful picture. You can see here with a little bit fantasy, like fried eggs and some chicken wire. Even if they become higher grade, they still look a little bit more organized, versus astrocytomas that are more infiltrative. And here you see a picture of a glioblastoma with pseudopolarizating necrosis and some new blood vessel formation. So it's fundamental for the understanding of the new classification to know about a number of biomarkers. And the most important 3 biomarkers I'm going to highlight in this talk. So you don't need to memorize more than these 3 biomarkers to understand most of the classification. So I'm going to start with a brief history of how these all came about. So the first study in glioblastoma that showed a survival benefit was the study by URTC, Stupp and colleagues in 2005. There was a companion paper that showed that patients with an MGMT promoter methylation, an epigenetic change, had better outcomes. So that was our first marker, MGMT promoter methylation. The second marker that really revolutionized our understanding of oligodendrogliomas was the co-deletion of 1p19q that also had clinical impact. The third marker that was discovered in 2008 in connection with gliomas was IDH1 and IDH2 mutation that is found in the vast majority of lower grade gliomas. So how do we make sense of all of this? And the classification really had to be revamped because now we had all these data points. And this was incredibly interesting as a clinician to experience the appearance of these markers and how do they change our management. So there were several papers that tried to make sense out of all of this, and with numerous neuropathologists and clinicians putting their heads together, we had a new classification in 2016 that integrated molecular features. Now we have the 2021 classification that I will break down in its most essential parts. So the first marker that I think is incredibly important for the understanding of what is high grade, what's low grade, and what the potential therapeutic implications might be is IDH1, IDH2. So this is a mutation in a metabolically active gene. There's an oncometabolite, 2-hydroxyglutarate, that is created that leads to epigenetic multiplication and modifications in the affected cells. The The second is the co-deletion of 1p and 19q, which in many ways is intriguing, because we find this truly in all oligodendrogliomas. Now defines what an oligodendroglioma is. It also represents the classic Knudsen two-hit hypothesis. You lose one allele, and then with a mutation you can lose the second allele. The breakpoint of this translocation has been characterized. There are some mutations that we don't completely understand what they really mean, but they are very frequent. So, with the integration of our molecular understanding, and also with the fact that we're now sequencing most of our newly diagnosed cases, we have way more information. So the one-liner pathology report doesn't really exist anymore. So now we have a layered report structure that was introduced also with the WHO 2021 classification. We have integrated diagnosis that combines tissue-based histological and molecular diagnosis. Then we have the description of the histological diagnosis that still reads like an old pathology report and really helpful clinically, I think, still. A more editorial change is that the grade of tumors is now in Arabic instead of Roman numbers. And then we have, at the end of the pathology report, a slew of molecular information that is added to really further fine-tune the understanding of these cancers. So in the 2021 landmark paper by Lewis and colleagues, this is I think, very important table. And you can see here that the most common gliomas we see up here is astrocytoma IDH mutant, oligodendroglioma IDH mutant, 1p19 co-deleted, and glioblastoma IDH wild type. With IDH and 1p19q, or the absence of these, you can really distinguish these three types. We're still using grading. Glioblastoma is always grade 4, and astrocytoma can become grade 4, or can be a grade 4 oligodendroglioma or grade 2, 3. It's really helpful in clinic when we have a patient with presence of an IDH mutation, because we'll say, you clearly do not have a glioblastoma. And that's, for patients that are often well-read when they come to us, that's a big relief that we can now focus on a different disease. So I'm breaking this down a little bit more in a little bit more visual figure. If you have a diffuse glioma, no matter what it looks like under the microscope, the first question is it IDH mutated or not? If it is, then it will either be an astrocytoma IDH mutant, not a glioblastoma, and then grade 2, 3, or 4. Grade 4 is either defined histopathologically by presence of microvascular proliferation and necrosis, or by presence of the CDK N2AB deletion. If you also have the 1p19q deletion, a 1p19q co-deletion, you have an oligodendroglioma, either low grade or high grade, that is much more treatable than other gliomas responsive to chemotherapy and so forth. If you don't have the IDH mutation, you either have a glioblastoma or one of the other types of IDH wild type high-grade gliomas, including diffuse midline gliomas. So we have a new technology that's emerging that's already integrated into clinical practice at some centers, is DNA methylation profiling. The cancer methylome shows characteristics of the cell origin and somatic DNA methylation changes. The profiling is highly robust and reproducible. You need very little tissue, and it's less interobserver dependent compared to standard diagnostics. It can also help correctly reclassify some tumors, and it identifies tumors that do not fit into existing classes. So this is what one of these cluster images looks like in a two-dimensional way, where this is a picture from the landmark paper by Kapper from the Heidelberg group. They classified 91 tumor classes. They have 9 control tissues they used. They used machine learning as an algorithm, and they could then assign the different diagnoses based on this methylation cluster. And they showed that some of the original diagnosis based on pathology alone with this methylation class could be reclassified to other tumors. This has in some cases been really helpful when we learned that some tumors are actually not as aggressive as others. Again, big sign of relief for patients. This molecular diagnosis can be really helpful. I'm going to give you one slide on glioblastoma, actually two, because Dr. Jalali will capture this, but I think the understanding of management of low-grade gliomas comes out of the understanding of high-grade gliomas. So glioblastomas, again, IDH wild type, and there's certain features that are associated with making this diagnosis. The treatment has not changed much over the last 20 years, which is greatly disappointing, and survival is still meager. One word about the third biomarker I mentioned, the MGMT promoter methylation. In the companion paper by Higgy and colleagues, we saw that MGMT promoter methylated glioblastomas had a better prognosis overall. We now know it's also a predictive marker for response to temozolomide. So this is how we believe it works. We switch off the expression of the MGMT repair enzyme, and then in the end, we have more effect from the chemotherapy through methylation of the promoter. So for glioblastoma IDH wild type, the glass is less than half empty. For oligodendrogliomas IDH mutant and astrocytomas IDH mutant, the glass, I think, is more than half full. So I'm going down from grade 3 to grade 2. And again, Dr. Jalali will provide more details of this. Previously, we called grade 3 astrocytomas anaplastic astrocytomas. The nomenclature has changed. There was a study comparing radiation alone or in combination with radiation temozolomide, either together or with adjuvant or without adjuvant treatment, the Cadnon study, that essentially showed, and there's still some controversy about the final data that is still pending, that if you have an IDH wild type tumor, there's in the vast majority of patients no benefit from temozolomide, whereas there's benefit from temozolomide in IDH mutant cancers. Standard options right now include, based on the study, radiation followed by 12 cycles of TMZ, or we can also still use, which we do at our center, concurrent chemoradiation with adjuvant temozolomide. We always encourage patients to go on clinical trials. Oligodendrogliomas, and again, as a reminder, we see these like this peaceful picture of these, fried egg appearing cells, much more organized, much more indolent than astrocytomas. This is from a very trustworthy site here from Wikipedia. There were two key studies in high-grade oligodendrogliomas that were designed prior to our knowledge about IDH mutation and also the presence of 1p19q. These were the American-Canadian study RTOG 9402 and EORTC 26951. What did they do? They compared radiation alone versus radiation in combination with chemotherapy with PCV, which is a combination of procarbazine, CCNU, and vincristine versus radiation alone. The studies both showed that overall survival was dramatically improved when we added chemotherapy to these cancers. Again, a proof that these cancers are highly chemosensitive. They used grading grade 3 for their analysis. We see that there's no separation in the curves initially, likely due to a testing error of what constitutes a 1p19q co-deletion. Survival was dramatically better, and dramatically in the sense of many, many years of a difference. So that's a huge survival benefit. If you double survival and go from 7 to 14 years, in glioblastoma, we talk about months difference, yet we're talking about years and years. What does this PCV regimen look like? And I would summarize it, it's very annoying. It's a very annoying regimen for the prescribers, especially but for the patients, because you have to really stay on track. The cycles are usually very long because of myelosuppression with procarbazine. So on day 1, you get CCNU with lomustine. Procarbazine, you have to be in a procarbazine diet. No wine, no cheese, no chocolate, no coffee. So a really terrible diet. And there's this vincristine part of this regimen, which we believe doesn't even really get into the brain, can cause neuropathy. But the survival benefit was so great that we're using this regimen in clinical practice. So based on this, there's now a clinical trial that's maturing, the CODEL study comparing radiation temozolomide with radiation PCV. This is relevant also for the treatment and treatment consideration for low-grade gliomas. So low-grade gliomas are slowly growing cancers, often non-enhancing, and by the time they're diagnosed, we often don't know how long did this patient have this tumor. Now we know that most of these patients have an IDH mutation, that they probably had this tumor for years and years and years. Maybe some patients were born with these tumors. There's a very helpful study out of Europe called the non-believer study, EORTC 22845. Why non-believer? So we don't believe that early treatment with radiation improves survival. That was the sort of the hypothesis. And you can see here, patients with low-grade gliomas, astros and oligos were lumped together. We saw that early radiation did not improve overall survival, however, progression-free survival, because the tumors continued to grow. What was this study that was done that is very similar to the studies I mentioned before in low-grade gliomas, that also was kind of an eye-opener for us. That was EORTC 98202. Patients under the age of 40 that had a gross total resection were observed, but everybody else, and it's a little bit of an arbitrary set of risk calculation. Everybody over 40 who had less than a gross total resection received either radiation or radiation and PCV. What did the data look like of this large study? Again, looked about very similar to the other study that we saw, about 8 to 13 year difference in survival. Oligodendrogliomas did the best, astrocytomas not as well. Now we know that these tumors would also be classified as only as astrocytomas if they had an IDH mutation. So we saw that IDH mutated tumors benefited from treatment very similar to that in high grade. How much does grade really matter at this point? That's one of the questions that's a hot topic. What did this study not answer? The study did not answer, can we still observe these patients? Do we need to treat everybody who's over 40 or who has less than a gross total resection? We believe that there's a great nuance in that. And then this study was done before we had a 1p90q status and IDH mutation status. And how does temozolomide compare with PCV? The same question as we have in high-grade gliomas. So when we have a newly diagnosed patient with a low-grade glioma, we have the option to observe or to treat. Previously, we just looked at radiation and chemo versus observation. That's like the polar opposite, like either toxic regimen or just observation. Now we have the opportunity to consider looking at IDH inhibitors. IDH is an interesting target because it's metabolically active, and there are now numerous approaches to study IDH in this setting. So a piece of Baltimore trivia, and where I got really hooked in neuro-oncology, I spent some time in Vogelstein's lab. The first day in the lab was when they sent the paper out, Bert and Will Parsons, on IDH mutated gliomas among the quote-unquote glioblastoma classification. So that was really cool. At the other end of the floor was Jim Herman in his lab and Steve Balen's group that discovered MGMT promoter methylation. And then there came the other biomarkers there. So I thought neuro-oncology is really like a super hot field. I still believe that. So anybody who's still in fellowship, neuro-oncology is the way to go. And then we had the first IDH inhibitor, ivosidenib, that showed that this is actually a patient of mine who had an increase in size here from blue to green to red, and then a shrinkage from blue to green to red on these inhibitors over many, many years. He was on for 5 to 6 years, actually. We saw some responses in non-enhancing, but also enhancing tumors. And that was really the first time that we saw a response to IDH inhibition in these cancers. The company designed vorasidenib as a second drug that also targets IDH2. Very similar responses seen and a duration of treatment. And then they did a randomized perioperative study comparing both drugs, ivosidenib and vorasidenib, and they showed that actually the effect on IDH mutant tumors was very comparable between the two. But the drug that was taken forward was vorasidenib, and you're probably aware of the landmark study that has now been published in the New England Journal of Medicine last year, that randomized patients to vorasidenib and a matched placebo. The primary endpoint was progression-free survival. Again, these tumors are very slow growing, and we have patients that had received no treatment except for surgery before. So really like a real-life scenario. The study showed, surprisingly very early, that there was a significant benefit in progression-free survival. And a positive study we define as if you can drive a truck through the two survival curves, and you can really do this here. Also, time to second treatment was delayed. You can see that the subgroup analysis was also favorable. We will likely not really find out what the difference is in overall survival because patients could cross over. So in the end, I'm just gonna say for one more minute, a glimmer of hope. We also have treatment options for BRAF mutated tumors and fusions, NTRK fusions, and H3K27 mutated diffuse midline gliomas. We know that BRAF is present in some of the rare tumors, but also some of the high-grade tumors. We using treatment with BRAF and MEK inhibitors in these tumors, there have been really beautiful papers over the last years that show there's a clinical benefit. NTRK mutations, sort of tumor agnostic. If you have a TRK fusion, you could benefit from larotrectinib and entrectinib. And then we see some benefit from a new drug called ONC201, some mild responses in diffuse midline gliomas. And there are new approaches, including CAR-T, that I think will be part of the discussion later. In summary, molecular diagnostics have revolutionized our understanding of gliomas. IDH mutations are fundamentally different, a different entity from glioblastoma. And vorasidenib is now approved. There will be other IDH-targeted therapies. This can be a meaningful choice for some patients with slowly growing tumors that would like to delay radiation. The questions about overall survival are still remaining. We need combination treatments, and the field is wide open for new treatments, and the bar is very low to make a difference. This is our group, and I thank you very much for this opportunity. And I apologize for speed racing through so much data, but it's, again, neuro-oncology is a wonderful field. If you're still making decisions about your future, please join us. Thank you so much.
Thank you, Dr. Holdorf, for that wonderful presentation. We'll take the question during the case presentations. So since we are running short of time, let's shifting gears. Let's move on to the next talk by Dr. Rakesh Jalali. I have the honor of introducing Dr. Rakesh Jalali. He is the he is a globally renowned radiation oncologist specializing in neuro-oncology and advanced therapies like radiation therapy, chemotherapy, brachytherapy, and stereotactic radiosurgery. He has developed the neuro-oncology group at the Tata Memorial Hospitals in Mumbai and recognized as the finest such unit in India and internationally acclaimed. He is the founder of the Indian Society of Neuro-Oncology and the Brain Tumor Foundation of India, supporting brain tumor patients and their families. He is a recipient of prestigious awards, including the Breast Oncologist Award by Medscape in 2014 and the Top Radiation Oncologist Award for 3 consecutive years. He is a prolific author with over 300 peer reviewed publications in leading journals like Lancet, Lancet Oncology, JAMA Oncology, and the JCO. He is renowned for his exceptional contributions to cancer care and mentoring the next generation of oncology specialists. And Sir is the professor and head of neuro-oncology at the Apollo Proton Cancer Center in Chennai. And over to you, Dr. Rakesh Jalali, for your talk on management of first-line management of high-grade gliomas.
Thank you very much, Dr. Vishwanath. I'd like to begin by expressing my gratitude to your wonderful organization, ASCO, and it's a pleasure to be with all of you as well as to connect with some of my colleagues. I hope you are able to see my first slide. Dr. Holdorf has actually given a very good introduction about the overall overarching principles and management of some of the high-grade gliomas that we see routinely in common practice, but I'll dwell a little bit more in detail, in particular about the first-line therapy of the high-grade glioma. The standard treatment for most of the high-grade gliomas still is a maximal safe surgery plus adjuvant therapy, which includes focal conformal radiation, plus some sort of systemic therapy, which is most likely in all cases, in most of the cases, a chemotherapy. And this is based on several pivotal studies. These are the two studies. They are not directly related to the temozolomide study. One was a very old study, which kind of set the foundation of combining adjuvant radiation along with carmustine nitrosoureas way back in 1980s. And there's a very interesting French study in the elderly where radiation was compared along only with supportive care and showed the benefit of adjuvant therapy. And hence, that is pretty much the standard of the therapy over a period of time. This was, of course, the landmark Stoops regimen, as we call it, based on the URTC and CIC study, initially based on phase 2 data, eventually a phase 3 randomized trial, very well conducted. One of the few trials where the phase 3 trial data actually of 26 to 28% 2-year survival mirrored a single arm phase 2 study, which was published a few years ago before, showing the power of the phase 2 as well as the translation into phase 3 as well. This was born in subsequent analysis of 5-year survival. And as you see, this is the current standard of treatment throughout the world, which is not only for glioblastoma, which has also creeped into the practice of other high-grade gliomas, and including some of the high-risk, low-grade gliomas, as you just heard in the previous talk. As was also mentioned, this was the first biomarker of MGMT promoter methylation, but also there were other factors, for example, the resection status, the age of the patient, whether the treatment was given completely, and that also has led to some extent, including the generation of RPA classes, which has helped us over a period of time to determine as to the intent of the treatment in some of these patients that we see in our routine clinical practice. Obviously, the question was in the MGMT promoter methylated cases, because there was a clear-cut benefit of adding an alkylating agent like temozolomide, can we make it a little bit more temozolomide? And that was addressed in a randomized trial, the RTOG 0525 study, where the adjuvant cycles were classic 5 days adjuvant temozolomide vis-a-vis a relatively intense 21 days regimen of temozolomide. And unfortunately, the overall trial was negative. The side effect profile was slightly worse, actually. But it was also one of the few trials which showed us a very importance of collecting the tissue specimen and basically validated the importance of MGMT promoter methylated with respect to other factors like age. And this also helped us to kind of fine tune our management in our clinical practice. There was an attempt by the German group to combine lomustine and temozolomide in newly diagnosed in first-line setting in promoter MGMT methylated high-grade gliomas, essentially glioblastomas. And while there was some indication of some benefit, but there were also some challenges in the toxicity. There was also some challenges in the way the data was interpreted. There were apparently some statistical challenges as well. And some of the editorials have tried to show us the level of underpower. And essentially, this has not really taken off as we would have liked to in our routine clinical practice. The first time we witnessed the benefit of anti-androgen therapy, we were blown away. I remember in my own self, I first saw in the SNOW meeting in 2007 in Dallas and what the power it had in the recurrent setting. There was a complete resolution of enhancement. The T2 flare abnormality was better. Patient quality of life was better. And therefore, it was no brainer that it had to be brought to the first line therapy. But as we all know, in the newly diagnosed setting, the two trials, the RTOG trial and the industry-driven Avaglio study, both failed to meet the primary endpoint of overall survival, although there was some benefit in the progression-free survival. It still remains an important drug. We use it quite routinely in many cases, especially in the recurrent setting in terms of improvement in their quality of life, in terms of pseudo progressions, in terms of radiation necrosis. There have been several attempts to use in MGMT unmethylated cases, for example, the Gliomas study, but overall in the newly diagnosed study, in the newly diagnosed cases, it has not really made the mark that we were hoping for. Just an Indian perspective that we have been using it for the last several years now, and we have now several biosimilars in the country, which are at a significantly lesser price, and we try to compare with the innovator, and we demonstrated there was equal efficacy and adverse event profile for these patients, so we can use it safely as well. There have been other attempts from lateral thinking. There was huge excitement from Dr. Stroop's famous trial of EF14, where there was a very novel way of thinking of using tumor treatment fields, the NovaCure, so-called the helmet that we use. And while there has been again a very good evidence in terms of phase 3 randomized data, 2:1 randomization, and subsequent analysis on meta-analysis as well as the quality of life, and there is no doubt that there was a significant advantage. But the patient compliance, the overall impact in the clinic, as we were hoping in different parts of the world, also the accessibility and affordability has still remained a challenge in many parts of the world. And while there was a benefit of this technique, it has still not made into every single patient. There have been other attempts. Our group also tried to look at from the radiation point of view. There was very good data generated whether the stem cell niches can be irradiated right at the beginning. And for the newly diagnosed glioblastomas, we made an attempt, and whether the ipsilateral subventricular zone, which harbors the niches, and we did the biomarkers of CD133, SOX2, and other stem cell markers and try to, but there is conflicting data as to whether there's an impact on the survival, whether you should use the ipsilateral side, whether it's the contralateral side. And while there are few studies being done, even currently, it has again not made a tremendous impact in the way we treat glioblastoma at the moment. And similarly, there were other attempts. There were different markers found. There were 4 types of glioblastomas also identified: the proneural type, which was IDH dependent, mesenchymal type, the DC vaccine, the many other studies were done from other point of view. I think Dr. Ahluwalia will touch upon some of them. But personally, I was hugely excited about NG-EGFR V3 vaccine because there was one study where phase 2 data was very strong. It had shown 2-year survival as much as 50% in GBMs. And this was an enriched population, not on pan anti-EGFR, only on the EGFR V3, and there was a vaccine against it. So the ACT4 study was involved a very large number of patient data, more than 745 patients, and unfortunately again revealed that there was absolutely no difference between the survivals, the overall survival being the primary endpoint. It was a little bit of disappointment that even in an enriched population with a very robust biomarker and a specific vaccine, it did not translate into meaningful benefit as we were hoping for. Again, one could go into it and try to analyze the data. Where was the impact? Where was the control population? The way we were looking at the EGFR V3. But essentially, again, it was a bit of a setback into the entire story. In fact, if we can summarize the past decade generally, and if I add the immunotherapy newly diagnosed studies on nivolumab, if you combine all of them as well, that generally speaking, it has been a disappointing trial in the newly diagnosed GBMs. There was anti-integrin, the Centric Salinity trial, and some of the trials which I've already mentioned in the last few slides. But if you summarize, there was a good statement made that among the 400 clinical trials since 2005, with more than 30,000 patients enrolled, testing various diverse treatment modalities in terms of surgery, radiation, systemic therapy, and name it, only one phase 3 trial in newly diagnosed and no phase 3 trial in recurrent glioblastoma demonstrated a meaningful survival benefit. And that shows the difficulty and the challenge of the true blue glioblastoma that we are dealing with. At the same time, however, there are some pockets, there are some advances which has made our practice a little bit better. For example, in the elderly patients, the short course radiation, there was a debate, especially from the Nordic study, whether to add temozolomide or only reserve to the MGMT promoter methylated with poor performance. But this study actually showed that even in those cases, addition of temozolomide with radiation is superior to radiation load, has become the standard of care between 65 to 90 years, with a median age of 73 years, was led by our Canadian colleagues, and also showed that even in both MGMT promoter methylated and unmethylated, there is a benefit in terms of outcome, in terms of survival. There is a great deal of enthusiasm from the surgical impact. We were always looking at the enhancing component, but a very nice study from MD Anderson demonstrated to us that it is not only the enhancing component, but also the T2 flare, which represents a slightly lower grade, but we note the deeply infiltrated with the modern technique of image guidance, awake craniotomy, the neuromapping, and DTI, and the functional MRIs. We have better equipment. And if you can remove more than 53% of the T2 flare, there was also a survival advantage. And there's a big push led by Hugus Dufau and many other people, essentially from lower grade gliomas, but being translated also in high grade gliomas using brain connectomes as to we can map out the neuropsychological, neurofunctional domain such that there is an enhanced surgical section, which hopefully will also translate into clinical benefit. And this has to be tested in appropriate clinical trials. As far as the radiation is concerned, we have also learned the power of meticulous planning, especially in terms of T2 flare. Infrequent, it's not infrequent, then we see that if you look at only the thick slices, we miss out some of the tumors. So we are now doing very thin slices, use the T2 extensions, the 3D FSPGR sequence, and many times, sometimes in the posterior fossa, especially in IDH mutant tumors, you will be amazed to see some of the tumor extensions, and that has also helped to some extent. But the standard of care is still hovering around 59.460 gray, and the standard of care is using a VMAT or an IMRT technology. We have also realized over a period of time the instance of pseudoprogression, the treatment changes. It's not necessarily seen in the 3-month scenario as the RANO criteria are. There's a new RANO as well now, and the RANO PRO is being incorporated in the clinical practice as well. But we have also seen that it can happen late term as well. Typically, they tend to be along the ventricles. The cortical seems to be more towards the tumor. The perfusion, the spectroscopy, the serial, and the symptomatology, the previous MGMT promoter methylation or IDH status, all but to be discussed in a joint radiology and joint neuro-oncology tumor board, will help a significant proportion of the patients. And we have either observation, a repeat MRI, corticosteroids, and judicious use of bevacizumab can help these patients to differentiate, but also manage these patients quite well. As far as our own Indian data is concerned, we started temozolomide. Actually, we were fortunate to start as back as 2001, when even the newly diagnosed data was not there. And over a period of time, we managed to publish a fair number of publications looking at different aspects of glioblastoma, gliosarcoma, poor prognosis, pediatric patients, erstwhile called glioblastoma with oligodendroglioma. And over a period of time, the data is more or less the same. We also realized that most of our 70 to 80% are generic or biosimilar, and they were 1/20th of the cost of the innovator. So we were looking at potential hematological toxicity, and Dr. Gupta and our group tried to look at in a series of hundreds of patients on this and found out a female gender, a serum creatinine, and anemia to some extent were potential, and there could be some genetic polymorphisms. And there is some data from the US, particularly from MD Anderson. And we also have seen occasional aplastic anemia or myelosuppression and also myelodysplasias happening, particularly with prolonged use of temozolomide. And this all helped us to fine tune the management as well in our clinical practice. So I have a few cases to demonstrate to you, which will illustrate some of the case series that we see. 47-year-old lady, grand mal seizure, 2009, called glioblastoma, MGMT promoter methylated, received conventional EBRT after resection, 6 cycles of temozolomide. That time, it was not clear whether you should give 6 or 12 cycles. Still, there's a bit of debate. Relatively done very well for several years, had a recurrence, was re-explored, re-radiation temozolomide, again doing well. And then when we did the analysis, we found out it was actually an IDH positive, which was not there available in 2009. And as Dr. Waldorf showed you, the 2016 classification to begin with, the update, and now the formal 5th WHO5 has demonstrated that the IDH mutant tumor no longer be called glioblastoma. They are called astrocytoma grade 4. And we did the ISNO classification of 2016, and we are now looking at 21 classification, and it has actually become 21 classification, has become much more simpler, and 3 or 4 markers. I also pay a lot of attention to ATRX, because ATRX loss literally tells you it's an astrocytoma grade 2, grade 3, grade 4, not only the IDH mutation, which can be seen in a relatively cheap method. It's not very expensive on an IHC. Occasionally, you may need a targeted sequencing when the suspicion is very high, and you don't need to treat it into elderly patients. So it has become much more simpler with the introduction of 2021 classification. The case 2 is a young lady which was called grade 3 WHO after resection. IDH was mutant, looked at oligo-like cells. In fact, the first pathology did not become 1p19q. As I mentioned, ATRX is retained in glioblastoma, IDH wild type, but also is retained in oligodendrogliomas. And ATRX is lost only on 2 or 3 other patients, like in high-grade glioma with pyloid features, sometimes a histone hemispheric glioma of G34, and otherwise it is largely retained in GBMs and of course in oligo. This was a classic oligo. You saw several pictures with the classic histopathological factors. We had 1p19q even before IDH, and we know their survival is extremely good, more than 15 to 20 years median survival, even if it is a grade 3. Mind you, we don't use the Roman numerals anywhere, so even if there's a Roman numeral, as per the new WHO classification, we have to change them into the Arabic numeral. As we know that several series, now the question debate, of course, is whether we should do PCV, which was shown in earlier, both the EORTC study and the RTOG, but increasingly a single arm study of RTOG and many of the other data has shown slightly better impact on temozolomide PCV with its own challenges. But this is being tested in the CODEL studies, and there are 2 other studies looking at it, including one study from Tata Memorial in India, and next few years will show us some of the data. I am particularly very excited about the imaging biomarker, the classic T2 flare mismatch, which is a hallmark when there's a mismatch of the IDH, particularly the astrocytoma. And if there is no mismatch, looks more like an oligo. And sometimes the oligo 1p19q in our country, the fish is slightly more expensive than others. So therefore, in routine clinics and MRI is very good in India and anywhere, because you don't need so much time. You get it done routinely. And if with a little bit of radiology colleagues, you can actually make quite a bit prediction, even if you don't have the full pathology workup. And a T2 flare mismatch is an excellent modality. We are a little bit passionate about the imaging biomarkers, both in medulloblastoma, and we recently published a very good perfusion marker of ASL-APT in pilocytic astrocytomas as a part of that study. Now, it was also mentioned the non-codelated IDH mutant and astrocytoma. It was called anaplastic. We now call them astrocytoma grade 3, which are now IDH mutant. It was shown that the benefit was seen in only IDH positive patients, but as per the new classification, almost every astrocytoma grade 3 in by definition is IDH mutant, ATRX lost. Very small percentage will have ATRX retained, even if they are astrocytoma, not oligodendroglioma. Now, the main question, interesting, was that the adjuvant temozolomide, we were always thinking it is the concurrent bit which is helping, but it turns out that the adjuvant temozolomide for 12 cycles makes a very, very important impact rather than only the adjuvant sitting, and that is the standard of care. As is the standard of care for the CODEL study for the oligodendroglioma, where we are testing between IDH, testing between RT-PCV or RT-temozolomide. But we also realized some of the other nuances which was shown thrown up by 21. For example, this young man, 35-year-old, very good section, right-sided, non-eloquent cortex, received surgical resection RT plus temozolomide, IDH mutant. This patient do extremely well, but within a 1.5 to 2 years had a massive progression. And there was a rapid downhill course with perfusion. We re-radiated, gave everything, but eventually we lost the patient. It turns out that these patients harbor this potential aggressive variant, what is called CDKN2NP, and this needs a fish, slightly expensive, but this is extremely important. Now, this happens very rarely in IDH mutant astrocytomas, only 5% in grade 2, and about 10 to 12% in grade 3, and about 30 to 40% grade 4 IDH mutant tumors. So routinely now last 2 to 3 years in our clinic and many other centers, we should use CDKN2NP in all recurrent setting, but also in the primary setting, especially if they are grade 3 or they have some unusual features, but potentially you can characterize them what's called molecularly defined high-grade gliomas. And there is also already some interesting data set coming looking at different targeted therapies against this co-deletion. In the next few years, maybe there will be some targeted therapy against this potentially deleterious and very difficult IDH mutant. You already hold You already heard the tremendous impact of IDH inhibitor. We are excited about vorasidenib, mind, which is a relatively small cohort of observation and only demonstration in PFS. But we are excited only in non-enhancing tumors. But IDH grade 4 astrocytomas, for example, can be non-enhancing. So we are looking at how to incorporate in aggressive IDH mutant tumors, grade 3, for example, harboring CDKN2 co-deletion, the cost versus benefit ratio, and many other factors which which may be there, and in the next few years is likely to have an impact. Very quickly, we also realize there's a small component of epithelioid glioblastoma, and 80% of the epithelioid glioblastomas would have BRAF V600E mutation. This is just one case, 2016, 4 years, disease-free interval. Initially, we didn't know it was epithelioid. At a recurrent setting, we realized epithelioid from 2020, re-radiation with proton, and she's been on dafrabenib and trametinib, and this we just published our initial series on the same drug, and she's doing extremely well. About 70 to 80% grade 3 PXAs and grade 3 gangliogliomas can also harbor. Grade 2 PXAs also PXA, there is no grade 1. Ganglioglioma can have grade 1. And some of the patients can be considered for the targeted therapy with or without adjuvant radiation after the surgical resection. And this has been borne by it's a recurrent setting. The ROAD trial, the pediatric setting is the Dr. Buffet's trial. And again, we have the question is the imaging characteristics, length of duration, toxicity, financial burden, and how to lower the cost. These are the challenges now in these sets of patients, including high-grade pilocytic astrocytomas as well. And pediatric high-grade glioma as a word is a different kettle of fish. Most of them are IDH wild type. Most of them could have histone, but that can be histone wild type. But we have identified, we do almost all pediatric high-grade gliomas now. The whole NGS, especially the fusions. Fusions are more important, although some of them can harbor PDGFR amplification, EGFR amplification, and the most difficult ones are the MYC amplified tumors, which have the worst prognosis. I want to show you one case of 13-year-old boy. It's a classic hemispheric glioma, presence in AYA population, OLIC2 negative, ATRX lost, and can have G34, can have R, or can have V as well. Very interestingly, some of them have PDGFR amplification. This child actually went on to receive dasatinib. It's slightly better than imatinib, but again, next few years is going to crystallize the benefit of these aggressive high-grade gliomas. And finally, in the last 1 year or so, we have recognized the impact, especially in some pockets of India, where there is co-sanguinity. We are increasingly seeing practically every month, we see 1 or 2 cases of congenital mismatch repair deficiency. It can be CMMRD, it can be Frank Lynch, it can be RRD, replication repair deficiency. For example, 9-year-old child presented with this seizure and had IDH positive. Now, no child should have IDH mutant tumor, but this did have, now we have few IDH young patient tumors as well. And we did the somatic and germline mutation, excellent response to immunotherapy. We otherwise don't use checkpoint inhibitors. Whether to use Nivo or Pembro is a bit of a question. Mostly we have been using Nivo in brain, but there is increasing evidence for Pembro. This child has shown excellent response, although last week only we have recognized that it's a small early recurrence now as well. So eventually they don't do well. But again, the combinatorial therapy in the next few years is going to help. But the recognition and sensitization, this might be there over there, the MSI and the TMBs and everything. We are now routinely doing less than 40 years of age, all patients, irrespective of their profile. We do the IHC looking at their MSI status. We also have the proton therapy now here, and there is some data there that the radiation-induced lymphopenia in gliomas could be a factor, because we were all thinking temozolomide, but it can be also the radiation. And because proton can spare a lot of normal tissue, based on 2 data sets from MD Anderson, we just published our data a few months ago in Neuro-Oncology Advanced, the potential impact of high precision radiation to decrease lymphopenia. And this is being tested in BN001 as a dose escalation study. The photon study was negative, but the proton study is awaited, and hopefully there will be some benefit in that as well. The diagnostic services in LMIC is a big challenge. The Asian Society of Neuropathology is looking at it. And essentially, I'll be happy to share this data set because many of the Indian colleagues want to know. It's not so difficult. All of us have to pitch in your healthcare planners, your management that with relatively simple markers, the Asia Oceania Adapter Series, which I'm very delighted to be part of, is likely to come up, which can have an impact, and David Lewis himself is our advisor, can have an impact not only in lower income countries, but also perhaps in some of the high income countries. And in our country, of course, we have to look at the shadow study where we can do the video call. There's also some data we were invited by ASCO to look at the drug development in lower income countries. So finally, I leave up to you the challenges in GBM, difficult biology, difficult clinical trial design, key problems of control arms, stringent clinical eligibility criteria, the RANO, the interpretation, the pharmacodynamics of brain penetration, the infrastructure, the very essential, robust biomarkers, although several from the molecular classification, which is the theme of this webinar, we have crystallized some of the data sets from glioblastoma. But I was inspired by Uday Krishna, who is my colleague, who took the tablet from Mahabharata, looking at the Chakravyuh of Abhimanyu, those who will resonate, and glioblastoma looking at all the hallmarks of cancers multiplied by thousand folds are there. And with surgery, radiation, I think we need Arjunas and Abhimanyus to look at it to come out of this very, very difficult situation of high-grade gliomas, particularly the glioblastomas, just essentially captures the challenge that we have. But hopefully with the advent of molecular biology and greater collaboration, there will be scope and better survival and better outcomes, at least in some subsets, but hopefully it will translate into more and more subsets of patients. With that, I thank you very much for your attention, and again, show my deepest gratitude to the organizers for organizing this webinar. Thank you.
Thank you so much, sir, for that such an insightful talk. It has been an absolute pleasure to have had Dr. Rakesh Jalali, who is the medical director of the Apollo Proton Cancer Center and the first proton cancer center in Southeast Asia, to have given this wonderful talk. Thank you so much, sir. And we'll take questions during the case presentation. And let's move on to the next talk. I would like to request Dr. Poonam Maurya to introduce Dr. Manmeet Ahluwalia, who is the next speaker.
Good evening, all. It's a pleasure to introduce Dr. Manmeet Ahluwalia. Yes, he's a Chief of Medical Oncology, Chief Scientific Officer, and Deputy Director, Fernandez Family Endowed Chair in Cancer Research at Baptist Health Miami Cancer Institute. He also served as the Miller Family Endowed Chair in Neuro-Oncology and Head of Operations at Cleveland Clinic, Brain Tumor and Neuro-Oncology Center. He leads research on glioblastoma radiomics and gender-specific differences in glioblastoma as a principal investigator and key investigator on major grants. He's pioneered FDA approval intent studies on blood-brain barrier disruption for brain tumors using a low-intensity focused ultrasound. He chairs key committees including the SWAB Brain Tumor Working Group and the Scientific Review Committee of the International Gamma Knife Research Foundation. He's published over 250 peer-reviewed papers and served as a leader in advancing therapies for brain tumors and metastasis. So honored with prestigious awards like the ASCO Fellowship, ABTC Career Development Award, and the Most Distinguished Physician Award by the API. So we welcome you, Dr. Manmeet Ahluwalia. Over to you, sir.
Thank you so much for the kind introduction. Are you able to hear me okay and see my slides?
Yes, perfect.
Okay, so it is such a pleasure. Thank you, Dr. Santosh and Vishwanath, for your kind invitation. And I could not be more privileged to be speaking with two of my very dear friends, Dr. Matthias Holdhoff and Dr. Rakesh Jalali, who've really done an exceptional job at giving two very eloquent talks, and so really difficult acts to follow. I was tasked today to talk about therapeutic options in relapsed glioblastoma. And I'm just going to start off with the NCCN guidelines, right? So obviously, you know, Dr. Jalali in particular talked about the challenges in glioblastoma. And so these are the NCCN options: bevacizumab, temozolomide, lomustine, or calmustine, or the combination of PCV that Dr. Holdhoff had talked about, and regorafenib. There are some other recommended regimens, which are combinations of lomustine, more with bevacizumab based on the BELOB trial, combinations of temozolomide and bevacizumab that we do. And then there are some drugs which are actually useful in certain circumstances. And in particularly, I would like to highlight the NTRK fusion inhibitors like larotrectinib, entrectinib, and then the BRAF MEK inhibitors, particularly based on the ROAR study data, as Dr. Jalali had talked about. So just, I know we have a very varied group. So just the studies that actually led to use of this modalities, this was the URTC 26101 study led by Wolfgang Wick, and essentially was looking at lomustine, which we have used for decades, and comparing that to lomustine plus bevacizumab. And as Dr. Jalali had outlined, when bevacizumab came along, we were also excited. We were seeing beautiful pictures, and then we realized those were mostly imaging artifacts. And a number of trials over the years that have been conducted, especially phase 3 trials, have failed to show any benefit of bevacizumab in any setting in glioblastoma. And this trial, basically in recurrent glioblastoma, was no different. And you can see pretty much overlapping curves with lomustine and bevacizumab, where patients who were treated with lomustine had 8.6 months survival. Patients who were treated with bevacizumab and lomustine were 9.1. So this was a confirmatory study, which was generated from BLOB study work done in Netherlands, and basically essentially failed to show any benefit. Then there was a lot of interest, as you know, in targeted therapies, and so regorafenib is basically a multi-kinase inhibitor that targets multiple pathways, including c-KIT. Dr. Jalali showcased a beautiful study with a dasatinib. There's been a lot of users of dasatinib, imatinib as well, drugs that targeted the c-KIT pathway. So regorafenib is one of them that targets the VEGF, PDGF, as well as c-KIT. And this was the RICOMA trial that was done actually in Spain, and which was interesting that this was a randomized trial, which actually showcased that there was no much difference on the progression-free survival on the left side of the curve. Basically, what is the story of our life is actually the progression-free survival in a recurrent glioblastoma trial is actually the time to next scan, whether that's 6 weeks, whether that's 8 weeks. But what was interesting was that in the overall survival, the patients who were treated with regorafenib actually had a longer overall survival with a very impressive hazard ratio actually of 0.5 compared to lomustine. But what was interesting was that the outcomes on the study were a little bit different than what we have typically seen with lomustine. And as you saw in the URTC study, the lomustine outcomes were closer to 9 months. And in this trial, they were actually much less than that. There was actually a study led out of the Agile Consortium. I'm going to talk about that in a following slide, which has actually failed to show any benefit or failed to confirm benefit with regorafenib in glioblastoma. And so, as was outlined by Dr. Jalali very eloquently, that there are numerous challenges on glioblastoma, with all the challenges that we have in terms of highly heterogeneous tumor, highly immunosuppressive tumor, a tumor that adapts very quickly to any therapies that we give it. It's highly infiltrating. We cannot get it out surgically. Then on top, we have challenges of identifying the targets, and then we have challenges of blood-brain barrier disruption. So according to the NCCN guidelines, the number one criteria or the way to treat these patients is actually enrollment on a clinical trial. Unfortunately, even in the United States, despite all the efforts of leaders like Dr. Holdoff and several of the leaders at marquee cancer centers, less than 10% of our patients really enroll on clinical trials. So there is now an effort going on to increase the clinical trial participation by improving patient access, making trials criteria less restrictive. And we also do know, unfortunately, a lot of newer agents are tested in the recurrent setting and then are abandoned. And I want to highlight a point here that till date, there is no therapy in recurrent glioblastoma that has even shown a single-day benefit in a randomized trial. So we use therapies based on essentially negative studies, and that's what led to the approval of bevacizumab in recurrent setting as well. So a lot of interest is there about precision medicine and oncology. You guys know it since most of you are medical radiation oncologists on this webinar. And the essence of precision oncology in cancer actually is basically you can have top-down approach or bottom-up approach. And what is a top-down approach is you're looking at 1,000 patients, you're checking for fidelity, you're looking at multi-omics, you can look at DNA, you can look at RNA, you can look at epigenetics now. Dr. Holdoff had talked about a lot of amazing work coming out of the Heidelberg group, improving even diagnosis. And then depending on what the vulnerability is, you can actually develop clinical trial using clinical assays. And our first major foray in this was actually work led by Brian Alexander, and Dr. Patrick Bennett, Dana Farber, multi-arm effort, the INSIGHT trial, and as was, previously alluded to, 2/3 of our patients essentially have MGMT negative tumors, and there's hardly any benefit of temozolomide in them. So this was an effort, looking at screening new drugs based on pathways, you heard about CDKN2 pathway being important, EGFR, PI3 kinase inhibitors, and depending on what the pathway alteration is, you could actually put people in these trials. Unfortunately, some of the early studies have not been as exciting as we would have hoped. Next, obviously, you heard about GBM Agile before, and this has been a large adaptive effort. A number of drugs have been tested. Unfortunately, so far, including regorafenib, the drugs that have been studied have not shown any benefit, but this is a way of screening out drugs pretty quickly. The other approach that I would like to highlight, which I think is very important in recurrent glioblastoma rather, is the bottom-up approach. And here what we are doing is same thing. You're looking at people at clinical trials, and then you look at the patients who respond versus patients who don't respond. And unfortunately, in our field, we have not been able to do that great of a job in brain tumors in really looking at translational aspects of our trials, because a lot of times, and I'll showcase a number of these trials with you, we do 40 patient trials. You may see some benefit, no benefit, and we don't know what to take or where to go from that. And so we said, okay, we were part of the Adult Brain Tumor Consortium, and with leaders like Dr. Holtoff, we actually, ran the study, which was a ABTC 1402 study, looking at a basic excision repair inhibitor, TRC102, and combining this with temozolomide. This was work, the drug was actually invented in Stan Gerson's lab, who was our cancer center director in Cleveland, and I had the privilege of leading this trial. Unfortunately, this trial basically was no different than any of the other trials. The progression-free survival was 2 months, time to next MRI. Progression-free survival rate at 6 months was 10.5%, very similar to what you've seen in other trials, and overall survival was 11 months. But 2 of the patients that I treated actually did really well, and they both had MPG expression, which was mechanistically holding true. But what we did was we interacted and collaborated with Mike Behrens at TGen, and we actually had transcriptomes done on these patients. And what we did was we showcased that those patients, the 2 patients who I had the privilege of treating, actually, who did really well with progression-free survivals of much more than we would see, actually had a gene signature which would predict for response. So this is actually leading to a trial that is being developed out of SWOG, and what we find out is that this DNA damage signature is only present in those patients who have MGMT methylated tumors. So it's basically a double hit hypothesis, because the repair when you treat a patient with temozolomide is actually either occurs to the MGMT pathway or the repair or the base excision repair inhibitor pathway. And so there's a trial that is being developed out of SWOG where MGMT methylated tumors will be treated with combination of TRC102 along with temozolomide and radiation. And we will validate this signature in a prospective manner. This occurs in around 10% of patients on the TCG analysis. And so 2 of the 19 patients, that's essentially 10%, who were treated on the study actually had this signature. Next, obviously, you heard before, a lot of excitement about gene fusions. And gene fusions, I thought, are really durable targets. And this was work led by Antonio Everone, which was a Science publication almost a decade back now, showcasing that FGFR tag gene fusions are present in around 3% of GPMs. And there were a number of drugs that were actually being explored in that pathway. And similarly, larotrectinib is a drug that actually was the first drug that was approved, as you know, for pan-agnostic tumors based on the NTRK gene fusions. And what we found out is that at least in CNS tumors, there are improved response rates of around 35%, 36% with these inhibitors. And obviously, this is not just GBM, but these are smattering of different tumors. But this is an option for your patients if you have NTRK gene fusions. Dr. Jalali had talked about it, as well as Dr. Holdoff. There is a lot of excitement about the BRAF MEK pathway, which is altered in select group of patients. And this was work that has now been carried on by Dr. Patrick Wen along with Dr. Vivek Sobaya, basically showcasing that you can use these inhibitors and then obviously confirmed by the ROAD trial, as was previously alluded to, that these inhibitors of BRAF MEK can have good outcomes in these patients who have BRAF alterations. Some of the challenges that was previously alluded to is that EGFR is another pathway that is altered in around at least 50% of our patients. And then there was a lot of interest in about immunotherapy. So I just wanted to complement what was discussed before. And we do know that, AbbVie had a very large antibody drug conjugate trial in EGFR that was run through the NRG consortium, work led by Andy Lastman, and essentially was a negative trial. There are still a lot of ongoing efforts now still targeting the EGFR. We do know that TKIs really are not very good opportunities in these patients. We recently participated in the Black Diamond study, the BD 1535 study, and we also participated in the ERASCA trial, both looking at inhibitors, more novel inhibitors targeting the EGFR pathway, and some of the initial results were presented at SNO and were not very gratifying. But there are other opportunities to looking at targeting at EGFR. They could include monoclonal antibody fragment immunotoxins targeting the EGFR V3. Dr. Jalali talked about the rindopepimid trial, unfortunately, which failed to showcase any benefit with the vaccine targeting this pathway as well. There is a lot of interest about CAR T cell therapies. Looking at anti-VG EGFR V3 variant again. We have BiTEs now, obviously coming, and BATs. We have bispecifics now, at least being approved for lung cancer. So these drugs are now coming into solid tumors, which is very heartening. There was obviously, as you heard, a lot of interest in immunotherapy. It's been transformative for a lot of other tumors. And unfortunately, in neuro-oncology, we have not had that kind of success. And Dr. Jalali had outlined, the patients who really have germline biallelic mismatch repair deficiencies. Those are the patients who really have a hypermutator type that actually get benefit from immune checkpoint inhibition. A lot of interesting work coming from Eric Buffet and their group out of Toronto. And this was the large first major effort looking at a randomized trial where nivolumab was compared to bevacizumab, and the story of glioblastoma, recurrent glioblastoma studies, no benefit. And again, you can see pretty much overlapping curves. One of the things that we recognized out of this trial was that patients who did well were those who were not on steroids, and patients who were on steroids did not do well with immune checkpoint blockade, which is only intuitive. And here you can clearly see those patients who were on nivolumab actually had an increasing use of corticosteroid use compared to those who were on bevacizumab. So we actually developed a trial out of Cleveland Clinic that was a randomized trial looking at nivolumab plus bevacizumab in recurrent glioblastoma. We actually looked at two arms, work coming out of the Mass General group in collaboration with David Reardon. And basically what their group had shown that maybe a low dose of bevacizumab would be better and would lead to less mesenchymal phenotype. And so we tried two different doses of bevacizumab in this trial. Arm A was the standard dose of bevacizumab. Arm B was a low dose of bevacizumab. And unfortunately, you can clearly see here that there was no improvements in progression-free survival or overall survival in both the arms. When we when we were doing the stats, we actually powered it using the BELO trial. So this was very much in alignment with the results that we see with either lomustine as per the BELO trial or bevacizumab. So, but what we did was in collaboration with Justin Lathia, looked at who's done a lot of work on myeloid-derived suppressor cells. We do know that myeloid-derived suppressor cells are present in glioblastoma 10-folds than a normal person, and these are highly immunosuppressive cells. And what we found out was that the patients actually on whom at least we saw responses actually had a decrease in the myeloid-derived suppressor cells compared to those who did not have responses. Dr. Jalali talked about a lot of interesting work being done in imaging. And one of the key areas, which is very exciting actually, is radiomics. And this was work that we did with collaboration with Pallavi Tiwari, who was at Case Western. She actually were able to develop predictive biomarkers, and we used some of this data. And actually this resulted in 2 R01s that we share with her and her group at looking at patients with glioblastoma and looking at radiomics for either both prognostic and predictive. Then, as we know, in other tumors, there is a lot of interest about neoadjuvant approaches. And this was work led by Tim Clausey and his group through the IV group. And at least in the initial trial, there was actually better outcomes seen with the neoadjuvant pembrolizumab. And Dr. Jalali outlined, their preferential better outcomes seen with pembro compared to maybe nivo. But the follow-up study that was done and presented at SNO by Dr. Wen failed to really confirm these results. So there are a lot of challenges with immune checkpoint inhibition in glioblastoma. There is a lot of interest in CTLA4 because it's upregulated in GBM. There's a much higher fraction of Tregs. We know Tregs are highly immunosuppressive again, and maybe that's the combination one needs to go after. Challenges with the CTLA4 inhibition, as you know, it's highly toxic. Some early work done with the company showed some benefit, but not too much to take it to large trials. There are multiple approaches that are going on in combination of oncolytic viruses. The captive trial, which was presented, showed some benefit compared to the historical controls, but the delta is not as much. A lot of interest in vaccine. We have done a fair amount of work targeting Survivin through the Cervax vaccine, which actually has shown really promising results in the upfront setting. Our recurrent study was done with pembrolizumab, so stay tuned. We should be presenting some of those results in the next coming years. Obviously, a lot of interest in CAR T cell therapies. There are multiple approaches, even looking at hypofractionated approaches, work done out of the Memorial Sloan Kettering group, or even combining pembrolizumab with LIT. Our group in Cleveland had done a lot of work on LIT, and then Andy Sloan led a study with pembrolizumab along with the LIT. So again, there is interest in even combining it with TT fields, as Dr. Jalali had outlined, a lot of interest in that. There was the Duke group had talked about, had done some of the initial work, which looked very promising with the recombinant poliovirus. But again, as you can clearly see here, there's only a very small subset of our patients, around 20% on most of the viral-based studies, that actually show a benefit. Unfortunately, we don't have really good markers to really predict who's going to get a benefit. More recently, this was a combination study, as I talked to you about the excitement about CTLA4. So this was tested in the NRG, again, work led by Andy Lassman, presented at the EANO conference last year, and basically showcasing, unfortunately, no benefit of Ipi-Nivo over patients treated with temozolomide in unmethylated setting. A lot of interest in vaccine. This was work led by David Reardon and my colleague David Pierboom, looking at SL701, which is a peptide-based vaccine that targets the IL-13R alpha A, afferent 2, and survivin. Again, recurrent study. This is one of the really the stories of our life. Really, most of our trials, which are 40 to 50 patients, we showcase some benefit in overall survival, like close to 50%. Similar results were seen in the captive trial. And we don't know what to do with it, because it looks marginally better than what we see in terms of large trials, where typically the OS12 now in more recent years has been around 40%, and we don't know what to do with it, frankly. But there was some eloquent work done in this study, basically showing that a higher CD8, CD4 ratio was associated with a longer survival. But most of these, we don't know if it's causality or it's association when we are measuring some of these things. Just building on some work that is now being developed is the VBI 1901. Basically, it's a vaccine that targets the CMV. A decade back, there was a lot of interest in it. And there's some early results, again, showcasing marginally better outcomes, but not something to really take home, but stay tuned, we'll get to know more about it. This was the more recent work presented out of the same group at SNO, basically showcasing that at least on a couple of patients who actually were treated here at Miami Cancer Institute got 2 PRs. But again, the PR percentage is close to 10%. We would like it to be like 20%, 25% to take it, to further approval studies. So some of the future directions, and Dr. Jalali had outlined, some of the ways to tackle that. And so there's a lot of interest, as you know, in window of opportunity studies. Mustafa Kasra and Mitch Berger are driving this effort to see if we can have a greater agreement. There is a very provocative approach out there, is longitudinal sampling. We know in other tumors like lung cancer or melanoma, you can do serial samplings. Unfortunately, brain is not as easy as to sample. Maybe we can use liquid biopsies. We are doing some work on blood-brain barrier disruption, where we are seeing a twofold increase in the cell-free DNA in the blood. And so stay tuned. We have enrolled around 44 patients out of 50, and we'll be sharing the data in the next year or two. So the way I look at GBM drug development is we typically has approached it like other oncologists do, and it's like a soccer match, more shots on goal, maybe more chances of success. Unfortunately, this approach has not been successful to GBM. So maybe a bold approach could be like a Apollo space program, which led to the first human landing on the moon in 1969. And this was not multiple shots at goal, but rather one space mission after the other to test each component needed for success and then adding on. And that's why you need a multidisciplinary management in glioblastoma to really take care of these patients. Unfortunately, the summary is that no therapy has shown any survival benefit in recurrent glioblastoma. Still, lomustine and bevacizumab are the most commonly used approaches in recurrent glioblastoma. Bevacizumab has been increasingly less used now. Clinical trial enrollment is still the preferred way to treat these patients according to the NCCN guidelines. For your kind attention and invitation to talk with you today.
Thank you, Dr. Manmeet, for that wonderful insights in the management of relapsed glioblastoma. So let's move on quickly to the case presentations. Now I request our first case presenter, Dr. Trisha Shetty. She's a second year DNB Radiation Oncology postgraduate from the AG Institute of Medical Sciences and Research Center, Mangalore, Karnataka. Over to you, Dr. Trisha Shetty, for the case presentation. You can start.
Good evening. A 54-year lady presents with complaints of seizures and left-sided weakness since 3 months. She's a known case of low-grade left frontoparietal glioma, diagnosed 13 years ago and was on observation. 3 months ago, she developed left-sided weakness and seizures. She underwent biopsy, following which she was admitted in ICU for about 2 months. She has now undergone cranioplasty. On examination, she is alert, oriented to time, place, and person. Power, upper limb 3/5, lower limb 5/5. Clinical stage astrocytoma, WHO grade 3. MRI brain was done, which showed superior longitudinal fasciculus and superior fronto-occipital fasciculus is displaced medially and is mildly edematous. Near total disruption of middle longitudinal fasciculus with residual fibers displaced laterally. Inferior longitudinal fasciculus and inferior fronto-occipital fasciculus is intact. Disruption of corticospinal tract fibers up to the level of basal ganglia, with majority of the remaining fibers displaced medially and posteriorly, and minimal remaining fibers anteriorly. Cingulate fasciculus is displaced medially with few of the fibers showing disruption. They also did CT brain on 9 June 2024. It showed ill-defined hyperdensity measuring approximately 1.6 into 4.4 into 3.8 centimeter, with surrounding hypodensity noted in the left frontoparietal lobe, causing mass effect in the form of effacement of adjacent sulci and gyri, and midline shift of 10 mm in the right side was noted. This is also seen to cause effacement of the ipsilateral ventricle with dilatation of the contralateral ventricle. Multiple extraaxial air foci was noted along the left frontoparietal convexity. Linear hyperdensity noted along the forks and left frontoparietal convexity, measuring 3.7 mm in the maximum thickness. Linear hyperdensities along the sulci of the left frontal lobe was noted. She then underwent biopsy, which showed diffuse infiltrating glioma, CNS WHO grade 3. Metastatic workup was done, which showed no disease elsewhere in the body. She later presented with symptoms like seizures and was then she underwent cranioplasty on 28 August 2024. A molecular testing was done, which showed IDH negative, P53 positive, ATRX loss, Ki67 was 7%, OLIC2 was positive, IDH1 mutation was present, 1P19Q correlation was negative, MGMT methylation by PCR was positive. Her post-op MRI showed altered signal intensity noted in the left frontoparietal lobe. Post-contrast study shows thin peripheral enhancement. Post-op CT brain was done on 29th August, which showed Calvarian flap was noted, multiple air foci along the left frontoparietal convexity, which suggestive of the post-op changes. Air foci was noted along the forks, which showed post-operative changes. Later, she was planned for adjuvant radiation therapy of 59.4 Gray and 33 fractions at 1.8 Gray per fraction from 14th October to 27th November. She was started with temozolomide 120 mg, 100 on her RT days, and right now waiting for the follow-ups. Yeah. The first question, correlation between morphological and molecular classification.
Dr. Matthias Holda, would you like to take this question?
Yeah, thank you very much. So I think It's a great presentation of a case. Seems like this is a grade 3 astrocytoma with several pretty classic features. The ATRX loss and also the IDH mutation. It sounds like this patient was quite advanced already at time of presentation, but I think this is really helpful. By any chance, did you have next generation sequencing data available as well?
No, I don't think the NGS was done in this patient. Right, Dr.
Yeah.
Trisha, was it done NGS?
Yes, sir, it was not done, sir.
Okay, thank you.
So, Dr. Trisha, you can move on with the next question.
Yes, sir. The treatment modality in glioma case, which was under observation and then it was progressed. Surgery followed by adjuvant RT or definitive radiation therapy is the choice.
Dr. Jalali, would you like to take this question?
Thank you, Dr. Shetty, for showing this very nice case. There are 3 or 4 observations I have. First of all, I think initially you said left-sided weakness. I'm afraid it must be right-sided weakness because the tumor is essentially on the left side of the tumor. So as you know, it's always the opposite side, right? So that is one small, you can confirm and rectify it. Clearly, it started with the IDH mutant low-grade glioma, which obviously progressed after 13 years, which is very good. In a young person, it was observed either consciously or not consciously, sometimes in India also, but eventually they do progress and now obviously has transformed to grade 3. Now, the second observation is in the glioma panel, and I'm just looking at the practical aspect, Dr. Vishwanath, from the country perspective. I saw it, I remember. So OLIG2 is positive, IDH mutation is in IHC. When you have ATRX loss, it is just for education purpose, it actually clinches the diagnosis of astrocytoma. So don't waste money on 1p19q because 1p19q is pretty expensive by the fish. It costs anywhere between 10 to 17,000 rupees. ATRX is 1,000 rupees, IDH mutation is 1,500 rupees. So it will save a lot of cost to the patient. And MGMT you did. There is some debate whether MGMT has any relevance in IDH mutant tumors, but nevertheless you did it. So that is pretty fair. So this was the second. Third, I was also intrigued from neurosurgical perspective. It seems to me they did a craniectomy to some extent and there was a flap noted and eventually they had to do a cranioplasty. And we try to avoid these things these days. We do a craniotomy. Mind you, it is relatively eloquent cortex. Speech area is also not too far. That's why you went into detail about the functional MRI, including the fibers of the corticospinal tract, the cingulate gyrus, the basal ganglia, which is excellent because it was helped. From surgical perspective, actually, the debate would have been in a young person, would you do an awake craniotomy or would you do a conventional craniotomy? So that will also help because it has delayed the radiation. You see, the radiation you started 2 months post-op because you had to do cranioplasty. It's again a kind of a learning point. But sorry about that. I just couldn't help observing these 3-4 points, what you showed. But your definitive question is, if it has progressed, surgery followed by adjuvant radiation is absolutely fine. But definitive radiation is not the correct. You have to debulk because it's a fairly large tumor. There was a mass effect. So it had to be surgery followed by adjuvant RT rather than going by direct radiation. And the third point is, of course, we don't do only adjuvant RT based on the trials that all the 3 speakers have shown you. It has to be combined with chemotherapy, which you have very nicely done with concurrent temozolomide, followed by 12 cycles of temozolomide on a adjuvant phase. So this will complete the current management of this type of tumor.
Dr. Manmeet, I think there are a couple of more questions. One is on the impact of molecular testing in this particular patient.
Yeah, so what I would add is Dr. Jalali highlighted a very critical component about the ATRX texting. I mean, it's just, a great observation. What I would state is we do know that, grade 2s and 3s, if you would overlap them from a molecular markers tend to behave, pretty much comparably. So if someone's got an IDH mutant glioma and then they have 1p19q deletion and basically oligodendroglioma, typically the outcomes are, 15 years or so. based on some of the recent trials, right? But if you have ATRX, and then basically you're an Astro, as in this case, the outcomes of those patients can vary, but they could, again, based on IDH mutation, could be anywhere between 5 to 8 years, depending on other prognostic features too, age, performance status, extent of resection, and others. And so these people still do better than those who are not IDH mutant, but not as good as those who have oligodendrogliomas. As far as the role of IDH mutant inhibitors is concerned, obviously, Dr. Holthoff presented the vorasidenib data. There's a lot of excitement about vorasidenib. The patients who were actually treated on the vorasidenib trials were actually grade 2 patients. And so we don't really have data for grade 3 patients. And what we definitely know is these drugs don't work in enhancing component. They actually work in low non-enhancing component. And also what we do know is that these patients do better compared to placebo. So for a grade 3 patient, I just want to make the point that radiation and chemotherapy is still the standard of care. And please do not replicate it until we have definitive data for these inhibitors. Interesting, intriguing data, mechanistic data in low-grade grade 2 patients, but not in grade 3 or grade 4, because a lot of us are getting a lot of emails and people are just extrapolating the trial data, and there is not definitive data to support the use of these inhibitors in grade 3 patients.
I think Dr. Holdoff has a point to add.
Yeah, first of all, I would say I 100% agree with your statement, Manmeet, that this is a tumor, and I think this case illustrated fairly advanced, long natural history, but this is a situation where radiation chemotherapy is what we would choose. We know that we can only extrapolate so much from the biomarkers, but the data are becoming more and more robust. One quick comment on the treatment approach for grade 3 astrocytoma. So the Cattenon study, what the Cattenon study did not compare is directly compares radiation chemotherapy together plus adjuvant versus radiation alone plus adjuvant temozolomide. So there's still a little bit unclear whether it's radiation and 12 cycles of adjuvant temozolomide, or whether the concomitant treatment plus adjuvant is superior. So there's still some uncertainty, but either approach we would think is acceptable. And take-home messages: IDH mutated tumors, and there was a question on the online questionnaires in the Q&A as well. Would we give if somebody is MGMT unmethylated less than 12 cycles? So we think in general, like MGMT methylation is important in these tumors. However, IDH mutation is trumps MGMT. So if you're IDH mutated, we treat them all as if they respond to temozolomide.
Dr. Vishnath, a small quick point. I think I mentioned in my talk also, the only other thing which we should do in this case is CDKN2NB co-deletion, because it's a recurrent case. It's been 13 years. Sometimes they acquired mutation, and CDKN2B deletion will actually help at the moment prognostically. It doesn't change the therapy dramatically. We are hoping there will be some agent which will target those, but there is still some time to go. But for a family spending 13 years, and there is this feeling that don't worry, still many years they will do, but CDKN2 co-deletion will help to prognostic, and it will also help to prepare the family and yourself for the future eventuality.
Sure. Thank you so much, sir. Let's move on quickly to the second case. Thank you, Dr. Trisha Shetty. So the second case presentation will be by Dr. Varsha Bhandarkar. She is my DNB Medical Oncology Fellow at Apollo Hospitals, Bangalore, Karnataka. Over to you, Dr. Varsha, for your case presentation.
Good evening, everybody. So today I'll be presenting a case of glioblastoma. So coming to the case, we had a 67-year-old female who was evaluated for incoherent speech since 1 week. And on an examination, the patient was conscious and alert. She did not have any focal neurological deficits. MRI of the brain showed a mass in the left temporal lobe, measuring around 27 into 20 mm with some perilesional edema. So for this, she underwent craniotomy and gross total resection of the tumor. So post-operative histopathology showed neoplastic astrocytes arranged in a diffuse pattern with moderate to marked degree of nuclear pleomorphism, along with microvascular proliferation and glomeruloid formation, which was suggestive of glioblastoma, WHO grade 4, which was MGMT methylated. And further, immunohistochemistry showed GFAP positive, IDH1 negative, and P53 negative. Next slide, sir. She received external beam radiation therapy with a dose of 60 gray in 30 fractions, along with temozolomide, and this was followed by adjuvant temozolomide for 6 months. She was on regular follow-up post this, and 5 months later, she presented to us with an episode of headache and an episode of generalized tonic-clonic seizure. At this point, repeat MRI of the brain showed post-operative changes along the left calvarium, and also noted was a heterogeneous area of focal enhancement in the left temporal lobe, measuring 2.4 into 1.9 centimeter with perilesional hyperintensity extending up to the parietal lobe. So in order to rule out any radiation-induced necrosis, we decided to proceed with DOPA PET scan. A DOPA PET scan showed focal tracer avid nodular enhancing lesion measuring about 20 into 16 mm with SUV of 4.6 in the left temporal lobe with adjacent white matter edema. She underwent left re-exploratory temporoparietal craniotomy and resection of the lesion. Post-operative histopathology was suggestive of glial neoplasm. MRI brain scan 48 hours after the surgery showed post-surgical changes in the left temporoparietal region, and there was no focal enhancing areas. So at this point, we discussed this case in Neuro-Oncology Tumor Board, and a DOPA PET was advised to look for any residual lesion. So DOPA PET scan showed only post-surgical changes in the left temporoparietal region. There was some mildly increased tracer uptake along the periphery. The rest of the brain parenchyma was unremarkable. So considering that there was no residual disease, and also keeping in mind that this patient had almost a 5-month disease-free interval, we decided to restart this patient on adjuvant temozolomide at a dose of 150 mg per meter square orally for 5 days, once in 4 weeks. And along with that, add targeted therapy injection bevacizumab. There's a mistake. It's 10 mg per kg once every 2 weeks. So at present, the patient is doing well. She's completed 2 months of treatment and she's had no further deterioration in her neurological status. So we also did an NGS for the patient to plan for subsequent lines of therapy in case of progression. And here we noted that there was a mutation in the TERT promoter gene, and there was a P10 frame shift deletion and copy number gain in the NRAS gene. So I've come to the end of my presentation. My first question is to you, Dr. Manmeet Ahluwalia, sir. So at this point, in case this patient progresses, keeping in mind this NGS report, what do you think would be the most appropriate regimen for this patient, sir?
So unfortunately, what we don't have any definitive evidence of using anything, very honestly. If you go, and I'm going to tackle question 1, 2 in this, any role for TTF, right? Because when we did the EF11 trial, what that showcased was that the median progression-free survival in TTF group was very comparable to the chemotherapy group. It was basically 2 months. Now, obviously, TTF was approved in recurrent setting, not commonly used. So we typically don't use it. I think the survival data is there in the first setting. So we use it in the upfront setting. But again, at our center, I think the usage of that modality is less than 5% at best. Pretty much in alignment with what we have seen at academic centers. The community centers seem to have a slightly higher usage, probably in the teens to 20s. But in most of our trials, we try to put patients on trials, frankly. So if you use TT fields, you'll get 2 months. But in the EF11 trial, actually, there was a very interesting hypothesis that we actually tested in the NRG through an RTOG Foundation study that I actually was the PI on, and that was post-Avastin. Actually, there was a very interesting hypothesis that the patients who got TT fields actually did better than other salvage therapies. Unfortunately, this was a hypothesis. We did the study, we ran it for a couple of years, and we could only put 3 patients on trial. Okay, in all the, I think the trial was open at multiple sites of RTOG, and typically RTOG or NRG has been pretty good in enrolling patients. So I say we have no definitive evidence that this helps, although we asked that question. So what I would state is that, again, the use of temozolomide and bevacizumab is on the NCCN guidelines, but we don't know if any one of the therapies is better than the other. The interest, there was a P10 alteration in this patient. There has been some
Yes.
interest in targeting that. There's work out of the group in San Diego looking at, FGFR inhibition, but that's more for upfront setting rather than recurrent.
Okay, and I had another question for you, sir. So in our hospital, we commonly use bevacizumab and irinotecan for our patients, but you did not say much about it during your presentation. So what do you think of that regimen, sir?
Do not use it. So the only reason we really tested was this was work coming out of Jim Rendenberg when he was at actually Duke. Okay, and it was just an extrapolation of what we had seen with colorectal patients. The driver there clearly was bevacizumab. It was clinical benefit. There is no, we ran a couple of topoisomerase 2 inhibitor studies with irinotecan kind of drugs. And actually, it was my first trial that I actually wrote as a resident, and 0 out of 14 patients had any responses. So in fact, we've actually taken it even out of the NCCN guidelines. When I served on that with Patrick, when one of the Patrick's contributions was to, clean out because we had too many therapies, really, we did not have benefit. I think it's not the easiest drug to follow, use. There is a fair amount of diarrhea and other challenges for the patient. So if we need to use anything, we tend to, at least I tend to, if I have to use anything with bevacizumab, I still use lomustine. There is some element to the B-lobe data, although it was not confirmed in a large trial. So if I have to use in a patient where I'm using Avastin more for symptomatic relief, frankly, than anything else, and the patient's methylated, I would obviously want to use lomustine, but I always go for an alkylating agent over bevacizumab unless it's symptomatically needed.
Dr.
Yes, sir. And
Dr. Jalalia has a point to say.
yes, sir.
So you're muted, sir.
Varsha, very good case, and this is not infrequent. So the thing is, if it was actually operated upon quite well, and first of all, you have to always think is a pseudo progression or a real tumor. But when it is towards the cortex, it was too solid, and of course, DOPA helped you as well. So it was absolutely correct way to go ahead. Although in pathology, you must ask, was there any treatment change? How much is the quiescent tumor? How much is the recurrent tumor? Many times you will see a residual tumor with some treatment change. They may call it glioblastoma, but that does not necessarily mean it's a recurrent tumor. So those are the subtle points you have to discuss with the pathology. The question, of course, is that I'm just throwing it aloud, and I can ask Matthias and Manmeet and Vishwanath too. Was there any need to give bevacizumab? Because there was no tumor left behind. So as Manmeet said, essentially it is for tumor symptom burden relief and the quality of life. And you know that's going to recur at some point of time. So why not hold it for future and let her perhaps put her on single agent lomustine being NGMT methylated, and subsequently you give bevacizumab plus CCNU. We have also practically for the last 3.5 years stopped irinotecan completely, and either we give bev alone, and we tend to give lower doses, not 10 milligram per kg body weight, and we tend to use lomustine, particularly if it is MGMT promoter methylated.
Dr. Matthias?
Okay, sir.
Yeah, do you mind if I follow up on that? I fully agree with that approach, and it's nice to see that we're doing the same thing. It's 8,000 miles away. That's you. So one of the questions about bevacizumab in this setting is that it was a go-to second line drug that a lot of people used. I mean, we have these. There is a role for patients that cannot tolerate higher dose of steroids. So if you have pseudo progression, sometimes you get away with a course of steroids, and you don't have the potential risk from bevacizumab. There's a question that you raise about what is the appropriate dose and frequency of bevacizumab, and I think there's been some debate and discussion. The dose and frequency. I saw that you gave 5 milligrams per kilogram every 2 weeks, and we agree with that. If we need to give bevacizumab, we don't need to give the 10 milligrams per kilogram every 2 weeks. We get away with just a little bit. I typically use 5 milligrams per kilogram every 3 weeks when giving BAF. The data out of MD Anderson looking at 7.5 every 3 weeks showed a favorable toxicity profile. So we, as little as possible, is my thought about bevacizumab in general. And it, as Dr. Alawalia said, it can also lead to this pseudo progression, pseudo response. So if you give lomustine with bevacizumab, it's very hard to know if there's actually a benefit from the lomustine. Regarding lomustine, it's an expensive drug, at least here in the United States, it has been remarketed. An alternative is to give carmustine. We do that. Sometimes it's nice because you schedule the patient, it's an IV, and once it's in, we know no patient cannot throw up. It's an ancient drug, but it works practically the same as lomustine as an option.
Quick rejoinder, Matthias, the lomustine is ridiculously cheap in India. We should export it to US. The cost of say 40 milligram capsule into say 160 to 200 milligram is not more than $20 or $30.
Wow.
So yeah, it's but most of the companies don't want to keep it because everyone wants the fancy drugs. And to some extent, some of us, including myself, we have pitched in several companies that you do keep the drug because a very important drug, especially after the BLOB study.
Yep.
So several centers still find it hard to get it sometimes, but it is very easily accessible and very, very accessible, very affordable.
That's
Dr.
good to know.
Dr. Varsha, one more question and then you can wrap up.
Yes, sir. So I wanted to ask Dr. Rakesh Jalali, sir, what about re-irradiation in this patient, sir? Would you consider at this point, considering there is no... Yes.
So it's too early and you have excellent resection and there is no need for radiation. So you could just keep it. I would just give lomustine for a few cycles and do it every 3 months to 6 months. At any point of time, if there is a recurrence, you could add. And after a year and a half, typically we used to do 2 years with high precision. You could do 1.5, 2 years later also. And you could use bevacizumab with hypofractionated regimen. And sometimes with conventional radiation if it is 1.5, 2 years down the line. So too much is thought about re-radiation, but actually the data is not so great as we think. So you have to be very careful as well as to the optimal use of re-radiation as well.
And
Okay.
one more question, right, Varsha? Last question that is about immunotherapy with recurrent glioblastoma. She has this last question. Dr. Manmeet, you want to take this question?
Again, the reality is there's no benefit till date. Okay, whatever data which is there in these single arm studies is soft, right? We have all these OS 12 or 50%, 55%. We really don't know what that means because when we do large trials, they all drop to 40%, and that's the baseline. First recurrence, your OS is really 9 to 10 months on trials. OS 12 is really 40%. Sometimes people will use data to showcase it's 28%, 30%. That was like a decade back, frankly. In more recent years, at least if it is in first recurrence, sometimes you have these surgical trials which make it even more selective. And you might have a little bit bump, frankly, in OS 12 to like 50, 55%. What I would state is that re-emphasize, at least in recurrent glioblastoma, there is no real therapy that has shown any survival benefit of even 1 day. So when you're seeing such patients, I think the clinical scenario of the patient and basic markers will help guide you. MGMT methylated, just use lomustine, which is cheap, fairly well tolerated. So the things to look at is cost for the patient, especially in India, and the quality of life. Those are the two most important things, frankly, that we go for. Now, if they have an alteration and you have inhibitors, you can go for that, like NTRK. You can use these drugs like larotrectinib or entrectinib if they're available. FGFR tag gene fusions, you can look at FGFR inhibitors. The data out there so far is soft, but maybe a better opportunity, or BRAF alterations if they're there. So those are really where there has been some data. Immunotherapy, it's been pretty soft. I mean, obviously we didn't cover CAR T cell therapy in a lot of detail. Again, the data is like very selective patients, not ready for prime time.
Yeah. Thank you. Thank you so much, all the experts, for that wonderful discussion. Thank you, Dr. Varsha. Now over to you, Dr. Rachin Shetty, for your concluding remarks and summary.
To conclude, I would like to thank Dr. Matthias Holdorf for his comprehensive and insightful presentation. and to Dr. Rakesh Jalali sir for his perspectives on management of high-grade gliomas. I would like to express my gratitude to Dr. Manmeet Ahluwalia for his excellent overview of therapeutic options in relapsed glioblastoma. And special thanks to Dr. Trisha and Dr. Varsha for their intriguing case presentation and experts for actively participating in the discussions. Our sincere appreciation goes to ASCO International team, including Ms. Sarah Bachman and Ms. Jessica Williams for their unwavering support and encouragement in organizing this event. I also want to extend my deep gratitude to Dr. Vishwanath, whose dedication and efforts have made this webinar possible, and to my fellow CPOM trustees for their continuous support. And a special thanks to Mr. Vijay for his invaluable contribution for logistics of today's webinar. And a big thank you to the audience for participation, which has truly made this session successful. And I would like to acknowledge today's sponsors, Dr. Reddy's Lab, Alchem, NATCO, and OncoMinds for their support. Thank you once again, and we look forward to seeing you at the upcoming ASCO-sponsored CPOM webinars next year. Wishing you all a Merry Christmas and a Happy New Year. Have a wonderful night. Good night.
Thank you so much for having us. Thank you.
Thank you so much. And sorry, we couldn't take all the questions in the chat box, unfortunately, in the interest of time. So hopefully they'll reach out to all the experts via email. We'll share all the email addresses.
Yeah, you are welcome to send us. We'll send it by tomorrow or in a couple of days.
Thank you.
Right.
Thank you.
Thanks, everyone.
Thank you
Fantastic.
so much.
Thank you, everyone. Have a great day ahead. Bye-bye for now.
Bye-bye.